Hi, everyone. I'm Tiffany Traina, an associate attending at the Breast Medicine Service at Memorial Sloan Kettering Cancer Center, vice chair in the Department of Medicine and section head of our triple-negative breast cancer clinical research program. Happy to be with you to talk about biomarker-based decision-making for patients with BRCA wild-type advanced triple-negative breast cancer. I'd like to first start out with a roadmap that shows just how many biomarkers we now have that have relevance for triple-negative breast cancer. And I think about these in sort of buckets. One that's near to my heart is the idea of a luminal androgen receptor-driven TNBC, and there's been exploration into using anti-androgens to target this particular subtype. We see that these are enriched with PI3 kinase mutations, and that might open the door to opportunities for interesting combination therapies. And we know that this subtype actually has presence of RB, and many have looked at the role of CDK4/6 inhibitors in targeting this kind of AR-positive TNBC. We also have the immune-enriched subtype, and here biomarkers such as PD-L1 or presence of TILs or even tumor mutational burden may actually allow for benefit from checkpoint inhibitors. And we've seen that the use of pembrolizumab is a foundational treatment in combination with chemotherapy for our patients who have PD-L1 positive advanced triple-negative breast cancer. And we'll come back to talking about this as well. Another category of importance are those with DNA repair deficiency. So we think about this historically as those patients with germline BRCA1 or 2 mutations. But we know that within triple-negative breast cancer, there may be other potential subtypes, even somatic BRCA mutations or germline PALB2 mutations or other signatures of HRD deficiency that could allow for benefit from agents such as platinums or the PARP inhibitors that are FDA approved, such as olaparib or talazoparib. And then another category that has had relevance in hormone receptor positive breast cancer and may have a place here as well is the PI3 kinase AKT mTOR pathway. So as you do your tumor sequencing, you may see PI3 kinase mutations, PTEN loss commonly in TNBC, and potentially an opportunity for AKT inhibitors in development that can target this particular pathway when combined with chemotherapy. Outside of all of these molecular biomarkers, we also have surface antigens that have allowed themselves to serve as targets for really powerful antibody drug conjugates. And so we've had TROP2 as a target and the FDA-approved ADC of sacituzumab. And we've, for ages, had HER2 as a really relevant target in HER2-positive breast cancer. And recently, over the past year or two, we've seen the profound benefit from trastuzumab deruxtecan targeting HER2 in a HER2-low population. So when we approach advanced triple-negative breast cancer, I challenge you to start thinking about immediately, where does your patient and that tumor stand in expression of particular biomarkers that can help frame the treatment recommendations we make? So we'll first start with immunotherapy. And Keynote 355 was really the seminal study that led to incorporating pembrolizumab in the first-line treatment of patients with PD-L1 positive triple-negative breast cancer. We know that this was a first-line study. Patients were permitted on regardless of their PD-L1 status. And patients were randomized to chemotherapy with placebo or chemotherapy with pembrolizumab, with the primary endpoint planned for PFS in PD-L1 positive patients. And PD-L1 positivity here was defined as either CPS greater than or equal to 1 or CPS greater than or equal to 10. And we'll look at this analysis together. Secondary endpoints included many other efficacy endpoints, and overall survival was also a very important primary endpoint. And now we've seen these data over time, but the addition of pembrolizumab to chemotherapy, to taxane or platinum-based chemotherapy combination, significantly improved progression-free survival. And we've seen more recent data with longer follow-up on overall survival benefit. And this benefit is particularly in the patients that have a tumor that tests with a CPS score of 10 or higher. So when you're thinking about definition of PD-L1 positivity, these days it is a CPS of 10 or greater. But you can see that significant improvement in outcomes. Now, I want to just switch gears a little bit and spend a moment on germline testing. And NCCN has actually updated their guidelines. You'll see that the recommendations for germline testing are much more liberal and inclusive than they once were. A diagnosis of triple-negative breast cancer reflexively should have you thinking about being sure your patient is tested for germline BRCA1 and germline BRCA2, because this is an actionable biomarker, now both in early stage disease, but as well as in advanced disease, because of the great benefit from agents such as olaparib and talazoparib. So we know that the indication for olaparib and talazoparib is having a hereditary germline pathogenic BRCA1 or 2 mutation. But what I want to share with you is some interesting data here in looking at a potential way to expand the role of PARP inhibitors in triple-negative breast cancer. This particular study is from the TBCRC, and it looked at single-agent olaparib in patients with metastatic breast cancer that had other germline mutations, including PALB2, ATM, CHEK2, and also somatic mutations that may affect HRD, including somatic BRCA1 and 2 in the absence of a germline mutation. You can see here as well ATM, PALB2, and many others that we often see in our sequencing. What is really encouraging to see is there was significant response from single-agent olaparib in patients who had germline PALB2 mutations, as well as patients who had somatic BRCA1 or somatic BRCA2. These were the mutations that really were most predictive for benefit from the PARP inhibitor. And so this study has actually expanded its enrollment. It is still open, accruing patients who have germline PALB2 mutations or somatic BRCA1 or 2. But nice to see that there may be an opportunity for expanding the place of PARP inhibitors. There's also an interesting study, the DORA trial that was presented just at San Antonio, that looked at the use of olaparib with or without durvalumab, here with a slightly different concept. Here, the utilization of benefit, if you will, from platinum was used as a predictor of potential benefit to olaparib. So the eligibility criteria was having had benefit, stable disease, or response from several cycles of platinum. Patients then could come on study to receive olaparib with or without durvalumab. And you can see in this really relatively unselected population, regardless of BRCA mutation status, median progression-free survival was about 4 months with the PARP inhibitor alone, and over 6 months with the PARP inhibitor in combination with durvalumab. I think this is a hypothesis-generating study. We're also awaiting randomized phase 3 data from another combination trial of olaparib with pembrolizumab. And so I think this is a space to keep an eye on. So I'm going to switch gears and talk a little bit about antibody-drug conjugates. And we're all familiar with trastuzumab deruxtecan from our HER2-positive space. And what's made a huge splash for our patients over the past year and a half or so has been the use of TDXD in patients with HER2-low breast cancer. Remember, this is an antibody targeting HER2 with the deruxtecan payload with a high drug-to-antibody ratio and a permeable payload so that we do see a bystander effect regardless of expression of HER2. So we're going to talk about DESTINY-Breast04, but we've wondered what is the HER2 low level in patients who have hormone receptor negative disease, what we once called sort of triple negative. And you can see in this data set, it looked like about a third of triple negative breast cancers classify as HER2 low. So this is a meaningful subset of potentially eligible patients for trastuzumab deruxtecan. Now, DESTINY-Breast04 was presented at FASCO just over a year ago in the plenary session. This trial enrolled women who had HER2 low, defined as IHC 1+ or 2+, but FISH not amplified. In the first-line metastatic setting, they were permitted actually to have up to 2 prior lines of treatment for their metastatic disease. They were randomized to TDXD or treatment of physician's choice chemotherapy, which could have included capecitabine, eribulin, gem, paclitaxel, or nab-paclitaxel. And I do want to call out that this was largely a trial for hormone receptor positive patients. About 90% of these patients were estrogen receptor positive, had received prior endocrine therapy. Most had prior CDK4/6 inhibitor. And there was only a very small subset of patients on this trial with hormone receptor negative HER2 low disease. Neil, did you have a question?
Could I just, yeah, for all the times I've heard about HER2 low, I never kind of appreciated what you just showed there on that last slide, that HER2 low is much less common in hormone receptor negative. Like, I didn't realize that. What's
Right.
the thinking behind that? Why do you think that is?
Well, I think that we've known for some time that HER2 and ER signaling pathways have sort of codependency there. I think that this is a space that we're looking at more closely to try to understand why HER2 low may be less common in hormone receptor negative. Maybe I'm a glass half full kind of person. I saw a biomarker expressed about 30 to 40% of the time and thought that was pretty terrific for what has really been challenging in TNBC to find actionable biomarkers. So I saw that as a positive finding.
No, it definitely is positive, but it's just really striking. I can't believe I never noticed this before, that it's so different than hormone receptor positive. So interesting.
Yeah.
Please continue.
Yeah, thank you. So we'll take a look at the benefits here, knowing primary endpoint for this study was specifically PFS in that hormone receptor positive subset. We know from the plenary session that this was a tremendously positive trial. The addition of the use of trastuzumab deruxtecan was superior to treatment of physician's choice. The study met its primary endpoint for both PFS and overall survival. What I'm sharing here is in that small subset, about 60 patients that had hormone receptor negative HER2 low breast cancer. And you can see the magnitude of benefit here is pretty comparable, about a 50% improvement in PFS with the use of T-DXd and about a 50% improvement in overall survival with trastuzumab deruxtecan as compared to standard of care chemotherapy. So although small numbers, really encouraging. I think we've got proof of concept here, and we see that in the indication that we have for T-DXd in HER2 low breast cancer. Other efficacy endpoints were similarly impressive. So if you look to the right of the slide, hormone receptor negative overall response rate with T-DXd was about 50% as compared to only about 17% with standard of care chemotherapy. And the benefit here, the durability of response was significantly longer as well with using the antibody drug conjugate. When we look at all the various subgroups, you can see at a glance that they all seem to benefit the use of or favor the use of trastuzumab deruxtecan. This interestingly includes patients who had stable treated brain metastases, which we know is a problem for patients with triple negative breast cancer, and even in those patients with rapid progression of disease, which is also an area of unmet need. So really consistent activity across the board. Obviously, we have to always balance toxicity and adverse events when we're talking about new agents. And I think most commonly when we look at grade 3 tox from trastuzumab deruxtecan, we see fatigue, some cytopenias such as neutropenia, some GI toxicity, having a decreased appetite, even a bit of nausea can be quite common. One of the more concerning adverse events is ILD or pneumonitis, and we've seen this in past trials. And I think as we have better monitoring, better intervention, really clear protocols on how to manage this, the all-grade ILD is somewhat lower in that 10 to 12% range. And that's actually what's summarized here, looking at the drug-related ILD in this particular study of any grade was about 12%. LV dysfunction has always been something examined with HER2 targeted agents, and thankfully that is uncommon with T-DXd. So we're always looking for other opportunities and places for highly active drugs. And the DAISY trial, I think, is also hypothesis generating, led to actually Destiny Breast 06. But this study looked at trastuzumab deruxtecan in a small number of patients that had HER2 ultra low, or HER2, not quite 0, but not quite 1+ to meet the definition of low. So they're calling this 0+. And here in the hormone receptor negative, HER2 IHC 0+, you can see a waterfall plot supportive of response rates here, almost 30% response rate. So this has really inspired additional study. The Destiny Breast 06 trial is testing and has tested trastuzumab deruxtecan up against chemotherapy of physician's choice, and the eligibility allowed for HER2 IHC of 0 plus, 1 plus, or 2 plus, based on central testing, again, FISH not amplified. And we really hope to see what that IHC 0 plus subgroup looks like when we eventually see these data. There are other studies looking at combinations of trastuzumab deruxtecan in HER2-low breast cancer. The Destiny Breast 08 trial looked at those patients with hormone receptor-negative breast cancer, adding capecitabine, adding durvalumab with paclitaxel, or even exploring capivasertib. So keep an eye out for these results as well. There is a platform study called the Begonia trial that examines durvalumab, the checkpoint inhibitor, in combination with other agents. I'm showing you just a summary of the different cohorts on this slide. This is a first-line trial, and what I'm going to share with you is the cohort that examined trastuzumab deruxtecan with durvalumab. Eligibility is shared across this platform. Patients need to have metastatic triple-negative breast cancer. They are treated in the first-line setting. They have more than a year disease-free interval. And specifically for the TDXD cohort, they allowed for HER2-low breast cancer, and they needed to have good organ function, including pulmonary function. So here's our waterfall plot from cohort 6, which was trastuzumab deruxtecan and durva. You can see in the first-line setting, regardless of PD-L1 status, overall response rate was about 60%. A small number of complete responses, and median PFS looking at just over a year. I will also share toxicity, not surprising, really largely driven by trastuzumab deruxtecan, perhaps a bit concerning when we combine two drugs that can have pneumonitis. So there were 8 cases of ILD with this combination, only unfortunately 1 with grade 5 ILD. I want to introduce in a moment another antibody drug conjugate, this one called Dato-DXd. Dato-DXd is targeting TROP2 and has the same payload as trastuzumab deruxtecan. So Dato-DXd has been explored in the Tropion Pan-Tumor-01 study. It is being explored in multiple solid tumors. Data has been presented in lung. What I'm sharing with you here, data from ESMO now some time ago, that was an early look at the data in breast cancer. And these patients, you could see at an impressive overall response rate of about 43% in a typical phase 1 population where, if you take note, about more than 70% of these patients had more than 3 lines of therapy. 8% of patients had a similar agent that had targeted TROP2. And yet, despite that, we were seeing high response rates at 43%. The main toxicity, even though this drug has the same payload as trastuzumab deruxtecan, the toxicity profile is a bit different. Most commonly, we see stomatitis or mucositis, a small amount of fatigue. There can be some mild nausea with it of any grade, and also a low rate of alopecia. But it's really mucositis that I think about with this agent. So in that Begonia trial that I introduced before, there is a cohort that has looked at Dato-DXd plus durvalumab. Remember, this is first-line triple-negative metastatic breast cancer, regardless of PD-L1 status. Here, overall response rates with Dato-DXd and IO was about 75%, and a higher number of patients achieving a complete response. Lower rates of discontinuation due to toxicity, and you can see the most common adverse events similar to what we saw in Tropion-01, where it's nausea, mucositis, and some alopecia. So really encouraging data here. This agent is being looked at in first-line metastatic triple-negative breast cancer in the Tropion Breast 02 trial. This study randomizes patients to either Dato-DXd or investigator's choice chemotherapy with some parameters based on disease-free interval and prior exposure to chemotherapy agents. And so this study is recruiting now, a global trial, and encourage you to keep an eye out for it and support enrollment. There are other agents in our last few minutes to talk about that are really exciting for triple negative breast cancer that do require biomarker for benefit. Another antibody drug conjugate is a HER3-directed ADC, again with that same deruxtecan payload. So this study was looked at in patients who had hormone receptor negative as well as hormone receptor positive, HER3 positive metastatic breast cancer. What I'm sharing with you now is the triple negative breast cancer cohort. In breast cancer, HER3 is considered positive about 30 to 50% of the time. Here in this cohort of about 50 patients, overall response rate was about 23%, duration of response about 6 months, median progression-free survival also about 6 months. So interesting to keep an eye out for this particular agent. Toxicity that is seen here, significant grade 3 toxicity with this agent is, again, nausea, diarrhea, fatigue, most commonly. Rare ILD, it was reported, I think, in about less than 2% of patients in this particular trial. Another interesting area to consider is around targeting ERB2. So here at the intracellular level, when we send off our sequencing panels, it's not uncommon to come across an ERB2 mutation unique to the tumor, even in patients that traditionally test negative for HER2 disease. There was a basket study, the SUMMIT trial, that looked at the tyrosine kinase inhibitor neratinib in patients with ERB2 mutated breast cancer. Many of these cohorts were directed towards hormone receptor positive disease, but there was one cohort for patients with triple negative breast cancer with ERB2 mutations, and they received neratinib in combination with trastuzumab. What I've highlighted on the right here in this waterfall plot is an overall response rate of about 33% in patients with hormone receptor negative ERB2 mutated breast cancer. I'll stop there. Neil, you had a question.
Just are these kind of the same as the HER2 mutations you see in lung cancer that respond to TDXD? And has TDXD been looked at in ERB2 mutant breast cancer?
Terrific question. So yeah, they're similar. They're similar ERB2 mutations. I don't know if TDXD is being explored in the space. We have had other studies before neratinib looking at a similar target, but I think this is the most mature actionable data.
Yeah, I remember when Pat LaRusso did the discussion on the HER2 low paper, she brought up HER2 mutant. Of course, it totally took off in lung. It's like first line therapy there.
Right. Right. I think it's really interesting to think about ways that we can potentially repurpose drugs that we've had if we just find the right population to use them in. Exactly.
Please continue.
So in the last couple of minutes, I want to touch on the AKT pathway. So you remember PI3 kinase, AKT, PTEN loss, PTEN altered tumors are not uncommon in triple negative breast cancer. And there have been several studies exploring this. We've had 2 phase 2 trials looking at AKT inhibitors in TNBC. The first was the Opportunity study, an encouraging phase 2 trial. Unfortunately, when it moved on to randomized phase 3, as shown here, there was really no significant improvement when the AKT inhibitor ipatasertib was added to paclitaxel in the first-line setting. However, we also have data from the PACT trial, which was a phase 2 study looking at capivasertib plus paclitaxel versus paclitaxel with placebo in patients first-line metastatic triple-negative breast cancer. As you can see on the left, progression-free survival looked significantly improved with the addition of capivasertib, and even overall survival sort of trending towards improvement in the altered population. Now, we have a larger randomized phase 3 study that has been conducted in this population, and we eagerly await the results. This is not to be confused with the data we've already seen, positive data from capivasertib in hormone receptor positive breast cancer, where that phase 3 has reported out. We eagerly await, hopefully, an indication for that drug. So last to share with you is a study that is now going on through the TBCRC, which looks at testing the AR antagonist enzalutamide in AR positive triple negative breast cancer and ER low breast cancer. This study has now grown to a 3-arm study, multi-center around the country, looking at either enzalutamide plus mifepristone, or standard of care chemotherapy, with the option for crossover for those patients who are randomized to standard of care chemo. This is rich with correlative studies built into it. And so I'm excited to partner with my colleague Rita Nanda on this trial.
I don't know if you know some of the stuff that's going on with enzalutamide and prostate cancer right now. It's really wild.
Combinations.
Really wild.
It really is. I mean, it's so active, and that's definitely their wheelhouse and focus area for sure. But, I think that it's exciting to see that there may still be a place for this in breast cancer. We finally have the randomized trial off the ground.
Yeah, it's going to be very interesting. I don't know if any of these cases are people on enzalutamide, but I'm just kind of curious. Do you see much side effects in women who get enzalutamide? Men, they talk about mental cloudiness and quote fatigue. Yeah. Do you see that in women?
So interestingly, in the phase 2 trial that was done with enzalutamide, we did see this very subjective kind of report of brain fog or cloudiness, or sometimes folks reported feeling better after they had stopped the drug. They felt a bit of clarity that they didn't realize they had as a toxicity while they were using it. But yeah, I think that it's been hard to quantify. Fatigue hasn't been so much of an issue. Excited to see how it pans out in this randomized trial.
All right, let's talk about your cases here.
So this patient of mine was a 62-year-old woman, normal genetics, actually first presented back in 2019 with a clinical T2 N0, ER positive but low, 30%, HER2 negative breast cancer. She was treated locally with neoadjuvant therapy with paclitaxel, which was switched to nab-paclitaxel. She progressed quickly through her taxane, so they switched her to dose-dense AC. She ultimately went on to have a mastectomy and had a small amount of residual disease, 2 millimeters, moderately differentiated, node negative. This disease was hormone receptor negative, HER2 negative. And so she was given adjuvant capecitabine for 6 months per the CREATE-X trial, and did well, but only for a brief period of time, because by the end of 2020, her doctor had been following tumor markers, which elevated, and that prompted doing some diagnostic imaging with a CAT scan that showed large volume mediastinal adenopathy, largest mass measuring about 3.5 centimeters. She underwent a bronchoscopy and biopsy, and that confirmed recurrent, poorly differentiated invasive ductal cancer that was triple negative and PD-L1 positive with a CPS of greater than 10. So she came to see me at this point, and I was actually screening her for a first-line trial that we had that incorporated IO as well as chemotherapy. And as part of that screening, she required an MRI of the brain that detected multiple CNS metastases, as well as having edema and shift, even though she was asymptomatic. So she needed to go directly to neurosurgery. She received whole brain radiation after that. And I began standard of care first-line therapy with gemcitabine, carboplatin, and pembrolizumab. This was back in February of 2021. And at her first set of scans, about 3 months later, she had achieved a complete response extracranially, as well as in the brain, having had radiation therapy. So she did well on this triplet until about late summer of 2021, and she was really running into a lot of difficulty with blood counts and thrombocytopenia. So we opted to drop the gemcitabine and just keep her on the carboplatin and pembrolizumab dosed every 3 weeks. She did really beautifully, had limited difficulty managing the drug, returned to work as a teacher, really tolerated well, and continued to maintain a complete response on her scans. Unfortunately, last December, she had a fall on the ice and had a traumatic fracture of C1, as well as a wrist fracture. ended up requiring neurosurgery and spinal stabilization and time in the hospital and then time in rehab. And so she had a bit of a holiday during that period off of chemotherapy, but did resume about a month later. And by summer, earlier this summer, continued to remain free of disease on her imaging and was beginning to feel a bit worn out from the cumulative effects of chemotherapy for more than 2 years. So we made the joint decision to actually hold her carboplatin as well. And so since June, she's just been maintained on pembrolizumab alone, tolerating that beautifully without any immune-related adverse events. And we plan to just continue close monitoring with imaging.
So what an incredible case. And I guess I'd be really curious to know exactly what the CPS was, do you know?
Yes. It wasn't extraordinarily high. It was in the teens, right? 10 to 20
Really?
range. Yeah.
And I don't
Yeah.
know, did you happen to have a TMB on her?
Not greater than 10 because we sequence as standard practice, we
Right.
sequence everybody in the first line sort of setting. And I rarely find TMB higher than 10.
Anyhow, incredible case. I guess
Yeah.
the question is why? Why is she different than other people who
Why?
don't do as well? But
Exactly.
anyhow, great
So
case.
yeah, hopefully this is a quite durable response. And she's not the only one. So I'll share another kind of great story. This is a young woman. She's actually a practicing physician. She was doing her routine screening. And back in 2019, on routine mammography, she was diagnosed with an ER-low, HER2-negative breast cancer involving both the breast and the nodes. Her doctor at the time performed staging with a PET CT and found not only thoracic adenopathy and intra-abdominal adenopathy, but liver lesions that were suspicious for metastases. And she had liver biopsy confirmed metastatic triple-negative breast cancer, HER2-low, here AR positive as well as PD-L1 positive. The PD-L1 testing at the time here back in 2019 was SP142. So here she was, greater than 1 allowed for being considered PD-L1 positive. Her germline genetic testing was normal. And so she started nab-paclitaxel and atezolizumab back in spring of 2019. And she, within about 6 months, had achieved a complete response in the liver, gradual resolution of the adenopathy, and only had kind of a small little residual breast mass. So by October of 2020, she was still working full time. She's a surgeon. We jointly decided to hold chemotherapy, right? Neuropathy would be really life altering for her. And with the continued complete response, she felt comfortable with taking a pause on chemo. She had radiation, definitive kind of local therapy to the small residual breast mass, and has continued on just atezolizumab as monotherapy since fall of 2020, and just had her imaging this summer, which again remains NED. So, I don't have many patients on atezolizumab. I'm not starting it for patients, but she had such an amazing response to that doublet that I've maintained her on the checkpoint inhibitor alone.
Again, I don't know if you mentioned this, the PD-1 level, I know it's positive, but do you know how high?
Yeah, so this was SP142 and it was just greater than 1%. It was barely.
Right. And the other question I have is, how do you define triple negative in terms of ER and PR? She had ER 2, 5%.
Yeah.
You're using...
So technically she would have been in her primary ER low. I think we've seen data to suggest that ER low breast cancer really behaves much more like a less endocrine sensitive cancer. And so often in practice, I will treat these patients as if they have a higher risk breast cancer. Her metastasis, concurrently tested ERPR 0%.
Would you have used hormonal therapy? Do you use hormonal therapy in people who have ERs and under 10?
In the adjuvant setting, I feel like where cure is at stake, I have a conversation with my patients about covering all of our bases, giving it a try just in case, right? In metastatic disease, I think it's less likely to be of benefit, but there are some patients that I will give a chance in that first line setting if they have limited volume disease, bone only, long disease-free interval, all those clinical characteristics that make you feel like this might be a more indolent hormone-driven breast cancer, particularly if a bone biopsy may give us a faulty reading on a low ER, but the clinical picture is consistent with an endocrine-sensitive cancer. I will try out a first-line endocrine therapy and keep a really close eye on those patients. And sometimes this tumor sequencing can give us some clues. So if you do molecular testing and you start to see mutations that are very suggestive of a luminal kind of breast cancer, I have greater comfort giving that opportunity at endocrine therapy.
If they happen to have had a 21 gene recurrence score, does that help also?
In the early stage setting, does it help?
Yeah, well, just to identify whether or not it's you would consider it ER positive or not.
Yeah, I think that we would tend to see high recurrence scores in those ER low tumors as a primary. And even still,
Right.
if they're coming back with a high recurrence score, I'm going to treat them with chemotherapy and then still try to do the best I can to cover even that ER
Right.
low staining.
Right. Right.
Uh,
All right. How about
Yeah.
your 60-year-old woman?
Yeah, so this woman had really, really remarkable experience. So she had had a very indolent, slow-growing mass for more than a year. Back in 2017, ultimately had breast imaging, which was suspicious. Biopsy confirmed a poorly differentiated invasive ductal cancer. Again, ER negative, PR low, HER2, 2 plus, but FISH not amplified. And had positive nodes at the time. So staging back in 2017 showed no evidence of distant metastases. And her oncologist at that time treated her with neoadjuvant AC followed by paclitaxel carboplatin. This is prior to the days of neoadjuvant pembrolizumab. And she went on to surgery in May of 2018 and had some residual disease within the breast, a large tumor bed, and 2 positive nodes. And these were technically ER positive, but 20%, HER2 negative, AR weakly positive, and node negative. So she went on to receive radiation. She was treated with adjuvant capecitabine for 6 months, and she started adjuvant aromatase inhibitor. And then unfortunately, in August of 2021, she presented to a local emergency room with chest pain and shortness of breath. And a PE scan revealed no clot, but unfortunately, a significant right upper lung mass, as well as mediastinal and hilar lymphadenopathy. So biopsy in September of 21 confirmed this was metastatic breast cancer, ER0, PR0, HER2 PD-L1 was positive with a CPS of greater than 10. And so she started first-line therapy with nab-paclitaxel and pembrolizumab with her doctor at the time. And rather quickly, really right after beginning therapy, within that month, she began to have blistering skin toxicity, both mucosal as well as along her extremities, her trunk. Treatment was stopped. They thought this was related to pembrolizumab. She had help with dermatology and allergy. She was given high doses of steroids. And by January of 22, they actually opted both to stop the chemotherapy because these blisters and wounds were really significant and very slow to heal. They had performed a repeat PET scan in December of 21, and it already showed significant benefit and response to just barely a month of therapy. So significant improvement, but quite impaired by the skin toxicity. She then was off all therapy for about 2 to 3 months and came to see me in April of 22. And at that initial visit, she could barely sit up. She was lying on the examining table, still had some healing scars from the skin reaction, reported significant shortness of breath, was having profuse diarrhea, non-bloody, but to the point that she was having episodes of incontinence. She wasn't eating. Her 80-year-old mother was helping to care for her, as well as her 2 teenage kids. She was in really dire straits. So we immediately admitted her to the hospital and started high-dose steroids since she had been tapered off the steroids from the fall. And she really had both the manifestations of dermatitis, pneumonitis, colitis, and adrenal insufficiency, all from just that 1 month of treatment. On imaging, on admission, she actually had resolved the FDG avidity that was previously there. She did have this evidence of pneumonitis in the lungs. And on bronchoscopy and biopsy, there was no residual malignant disease. There was just tremendous inflammatory changes in organizing pneumonia. So she had tumor sequencing and had a somatic BRCA mutation found. I actually had her off therapy altogether, just trying to recover from the really profound immune-related adverse events. And it was a very slow recovery, but she was able to actually enjoy that summer of 22, work on getting stronger, maintained on just maintenance levels of hydrocortisone. Unfortunately, in December of 22, she had some visual changes, and that prompted brain imaging that found some sub-centimeter metastases. So those were able to be addressed with SRS, but she still had no evidence of disease outside of the CNS. But given that progression and her improved performance status, back in December, I started olaparib, right, based on the somatic BRCA1/2, supported by the TBCRC published data. And she's done beautifully well with the olaparib, tolerating that much better, but does require stress dose steroids here and there, given the really profound impact that immunotherapy had for her.
Wow. That's one major story. She
Yes,
sounds like a very, very
yes.
tough, strong woman too, to have gone through all that. That is wild. Wow.
She sure is. And I think it's a reminder, it's really sobering to really feel the power that these drugs have and what manipulating the immune system can do. And so I'm very cautious and always keep these organ systems in mind that really anything can become inflamed with these checkpoint inhibitors. And we need to remember that now that we're using a lot more checkpoint inhibitor in early stage disease.
Well, there's a lot of debate about whether there's any relationship between autoimmune toxicity and benefit, but hopefully that would mean that she's going to do really well.
Right,
We'll see what happens with the olaparib. Is really fascinating. Wow, incredible case.
Yeah.
I'd like to meet that lady. I'll tell you, I'd like to talk to her.
I know.
Wow.
He's had quite the experience.
And it sounds like probably pretty good, pretty interesting experience for you getting her through all that. Wow.
Oh, I mean, it's really remarkable to see how steroids turn things around. It really did.
Dr. Lacouture, was he involved with this at all?
He sure was. Absolutely. Absolutely. My go-to.
Yeah, I guess so. All right. How about your last patient here, the 68-year-old person?
Absolutely happy to share. So she is also a practicing physician who palpated a mass back in 2019 and actually was diagnosed with multifocal left breast masses as well as a left axillary mass. So on biopsy, she had ER 50%, HER2, 2+, but FISH not amplified in one lesion, and another ER only 10%, HER2 negative or HER2 low, FISH not amplified. She went on to have neoadjuvant therapy with ACT, and then went on to mastectomy and axe dissection. And she had two distinct foci of breast cancer. One that essentially, as we've been talking about, really ER low. I'm thinking about this more as like a triple negative breast cancer, PR0, HER2 1+, and then a separate focus of ER 20 to 30%, HER2 low, but more than 10 lymph nodes involved. So T1 and 3, really high risk disease. So we treated her with anastrozole. She received post-mastectomy radiation, and she received capecitabine for 6 months based on the ER 1 to 5%, a la CREATE-X. So really trying to throw the whole kitchen sink here, including adjuvant zoledronic acid. However, unfortunately, last year, she was having bony pains that on imaging revealed bone metastases. Biopsy confirmed ER0, HER2, again, HER2 low, FISH not amplified, PD-L1 negative. Her Guardant testing revealed an ERBB2 mutation, so we keep that in the back of our mind. But there was nothing else remarkable on the tumor testing itself, on the biopsy. So she was treated in the first-line setting with carboplatin and denosumab. 3 months later, no improvement whatsoever. In fact, progression right in the face of carboplatin with multiple uptake throughout multiple bones. The axillary nodes got a bit better, but as of October of 22, we saw the amazing data that we knew from FASCO at the plenary in 22, and she was a perfect candidate for her starting her first cycle of trastuzumab deruxtecan. So she has tolerated that quite well. She's had a beautiful response as of January and again on most recent scans. And so she is continuing on trastuzumab deruxtecan and her bone remodeling agent. Thankfully, no pulmonary toxicity to speak of. She's maintained her hair, which I know is a concern. We're not quite sure what the benefits of scalp cooling are here, but she's been able to maintain that and continue working, which she's doing all the things she wants to do.
You know, I was just flashing on the fact she actually not only is HER2 low, but she also has an ERBB2 mutation.
Right.
Now, you know, getting back to, I was just flashing on the fact that actually in lung, they have data on both HER2 mutant and HER2 overexpressing, and actually they're higher response, they're higher with HER2 mutant. But
Fabulous.
I mean, I guess
I'd love to see that.
They're not as, yeah, no, there's no doubt. You look at the waterfall plot, it's much, and matter of fact, they're using it first line with mutant and they're not so sure about but I guess there are not enough breast cancer patients for you to know really how they would respond.
Right. I think this may take some time, and then we can try to go back and do a retrospective analysis and finding those